Good morning. In this video, we are going to review what we have said in class yesterday and add a few pieces of information that are important and that are necessary to know before answering the classwork questions and the homework questions. As we said before, the lung is surrounded by a double membrane, which is called the pleura. And the pleura is a double membrane consisting of two layers. A layer that is adjacent or adherent to the lung tissue, and this layer is called the visceral pleura. And we have another layer, this is the visceral pleura. Of course, this circle focuses on this part of the diagram. So you have here a part of the visceral pleura, which is blue in color, and the parietal pleura, which is adjacent, the layer of the pleural membrane that is adjacent or underneath the ribs and the intercostal muscles. So here we have sections of the ribs and the intercostal muscles. There is in between, there is a minimal space that is called the pleural space, and that pleural space contains a minimal amount of pleural fluid. Where does this pleural fluid come from? It is secreted by the cells of the pleura. So the cells of the pleura, or the cells that form the membrane of the pleura, are secretory cells. So this pleural fluid is secreted by the pleural membrane itself. The pleura has, being a double membrane with a layer of fluid, a minimal layer of fluid in between, has several important functions in the lungs. First of all, the pleura is protective. We're going to open a screen in order to summarize the functions of the pleura. So here, the functions, the important functions of the pleura. Mainly, the important functions of the pleura are all derived from the fact that it is protective. So the pleura essentially has a protective function. And now we're going to explain several examples that show how the pleura is protective. First of all, the pleura is protective because the visceral pleura that is adjacent to the lung tissue cushions the pleura. And by cushions the pleura, I mean that it covers the pleura and helps absorption of shocks. So whenever you're hit or you are exposed to mechanical trauma, then there will be absorption of shocks. So we have discussed before the functions of the pleura, but very briefly. And now we're going to expand our knowledge about the pleural membrane. So the visceral layer of the pleura, which is adjacent to the lung, cushions the lung. And by cushioning the lung, we mean that it does not only cover the lung, but it also absorbs shocks. So it absorbs shocks whenever there is mechanical trauma. And then we have another protective layer of the pleura that is related to both layers. I mean the visceral layer of the pleura and the parietal layer of the pleura. Both layers of the pleura secrete fluid, as we said before. So both layers secrete fluid, and that fluid, when present in normal amounts, will prevent friction between the two layers of the lungs. Why would there be any friction between the two layers of the lungs? Because there is all the time, or there are movements of inhalation and exhalation, expansion of the lung and contraction of the lung. So these expansive and contractive movements of the lung result in movement of the two layers, the visceral layer of the lung and the parietal layer of the lung over each other. So if there is no fluid in between, there could be friction, and the friction causes inflammation. So the fluid prevents the normal, of course, pleural fluid secretion. This will prevent friction between the two layers, the parietal layer and the visceral layer during lung movements. And by lung movements, I mean inhalation and exhalation. Of course, there is another factor or another structure, function, adaptation that is related to both layers, which is that both layers are smooth. And when both layers are smooth, this also prevents friction between the two layers. A third function of the pleura, of both layers of the pleura, that both layers of the pleura are richly supplied by blood vessels and are richly supplied by lymphatics, and both blood vessels and lymphatics carry white blood cells that help protection against inflammation. So both layers of the pleura act as barriers against inflammation. A fourth important function of the pleura, which is a bit more advanced or requires more understanding, is that the two layers of the pleura prevent collapse of the lung. They prevent collapse of the lung, and they do this, preventing collapse of the two lungs, by keeping a negative pressure inside the pleural space. This is important. Maybe it's not written on the slides in the part on the pleura and pleural effusion, but it is important to understand a very important disorder that we'll be discussing later on, which is pneumothorax, and we will be mentioning this also in pleural effusion. And maybe I mentioned it in class when I said that aspiration of fluid from the pleural space should be airtight, because if air bubbles enter the pleural space, this will result in collapse. I'll be explaining this in more details on this screen or on the next screen. So the presence of the pleura and the pleural fluid prevent collapse of the lungs by keeping a negative pressure inside the pleural space. And we will be opening a new screen in order to explain function number 4. Now, if this is the lung, one of the lungs, say for example, the right lung, and these are the two layers of the pleura around the lung, the visceral layer that is in contact with the lungs, and the parietal layer that is in contact with the thoracic cage from inside, or lining the thoracic cage from inside, and this is the fluid that is between them. So the lungs during exhalation tend to recoil. They tend to return to their original space and resume their original small volume. This is helped by elasticity of the lung tissue, and that's why we call it elastic recoil. So what is elastic recoil? Elastic recoil is the tendency of the lungs to return to their original position because of, or helped by, their elastic nature. So tendency of the lungs to return to their original position, and therefore their original volume, And this is helped by elasticity of their tissues. So there is an inward pulling force, which is the elastic recoil of the lung. And the visceral pleura tends to move inwards together with the lungs because the visceral pleura is adherent to the tissue of the lung. But meanwhile, the parietal pleura is attached to this thoracic cage with the ribs and the muscles in between, and therefore there is a pulling force that pulls on the parietal pleura in the opposite direction. So all the time you have two opposing force, a force that pulls inwards and a force that pulls outwards. And this creates a negative pressure inside the pleural space. What happens if this negative pressure is no more negative? Or what happens if this pressure increases, becomes zero, or even becomes positive? If the pressure increases in the pleural space, if the pressure increases in the pleural space, this will result in compression on the lungs, and the compression on the lungs will result in collapse of the lungs. And of course, if the lungs collapse, this means that the air sacs are closed, and if they are closed, so there is no exchange, no oxygen reaches the tissues, and therefore this might result in death of the person. Of course, when I say, what does it mean that we have a negative pressure inside the pleural space? We mean that it is pressure less than the pressure in the lungs, less than the pressure in the lungs. And usually it also means that it is less than the pressure, than the atmospheric pressure. And now we'll be moving on to the next slide. So the pleura, as we said before, is a double membrane that lines the thoracic cavity. And when we say it lines the thoracic cavity, we mean it lines the chest wall and encases the lungs. As we said, it covers the lungs or it cushions the lung. And the verb cushion includes protection and includes absorption of shocks. That's why it's preferred to covers or encases. The layer of the pleura that lines the thoracic cavity is called the parietal pleura. The layer that covers or cushions the lungs is called the visceral pleura. They're both smooth layers. They're both made of very smooth connective tissue. They both contain blood vessels and lymphatics. And of course, we forgot to say something very important, that they contain nerve endings, sensory nerve endings. And the fact that they contain sensory nerve endings is very important because if there is an underneath inflammation or mass tumor, whether it is a benign tumor or malignant tumor, it might cause irritation of the nerves in the pleura and might cause, as we said before, sharp pleural pain. We said this in class, that the pleural pain is usually sharp pleural pain if it results from inflammation or a lesion that affects the pleura. A lesion means a disorder or something abnormal that affects the tissue of the pleura. So the pleural layers do not only contain blood vessels and lymphatics, but they also contain sensory nerve endings. And we said that the pleural cells are able or are capable of secreting a pleural fluid that is very protective to the lung because it protects against friction and it makes the two layers very slippery, and therefore we diminish friction. And when we diminish friction, then we diminish inflammation. Because if there is friction without protection, friction will result in inflammation, of course, due to tissue injury and histamine release. Whenever there is friction, friction is a kind of mechanical trauma, and mechanical trauma simply means, if you want to understand why it leads to inflammation, mechanical trauma simply means cell injury, and cell injury simply means release of histamine, and histamine is the mediator of inflammation, as you know. Now, as we said before, there is a minimal amount of fluid between the two pleural layers, but if there is an abnormal accumulation of fluid in between the two layers, abnormal accumulation of pleural fluid in the pleural space, then this is called pleural effusion. So usually there is a minimal amount of fluid, but if there is abnormal accumulation of fluid in the pleural space, this is called pleural effusion. Here we can see in the diagram that we have the trachea, and then we have the two layers of the pleura. We have the lungs, and pleural effusion is this fluid that is shaded yellow in the diagram, but usually it's not yellow. So the pleural effusion is the fluid here that accumulates between the two layers of the pleural space, and you can see the buildup of fluid. Of course, as we said before, the buildup of fluid starts in the angle between the diaphragm and the lungs, like this angle, for example. This is the diaphragm, and this is the wall of the chest cavity. So the fluid starts to fill this angle and then increases gradually. And as we said before, the upper level of the fluid is usually concave. This angle between the diaphragm, this angle between the diaphragm and the chest wall is called the costophrenic angle. The costo means ribs, costophrenic angle. Costophrenic angle. And we will be seeing this on the x-rays on the next slides. But now we are going to discuss something very important, which is the cause or the pathogenesis of pleural effusion. And this will explain most of the information that is on this diagram. But what you are responsible for is what I'm going to explain on the screen, since there are certain terms here in the diagram that are a bit advanced and require more intensive or extensive explanation. So you're not responsible for every word that's in the diagram, but you are responsible only for what I'm gonna say on the following screen. So what is the pathogenesis of pleural effusion? We will open a new screen. So pathogenesis of pleural effusion. Pathogenesis of pleural effusion, or in other words, how pleural effusion is formed. So when I say explain the pathogenesis of pleural effusion, I mean explain how pleural effusion occurs, or what's the underlying abnormality and pathology that causes pleural effusion. Pleural effusion is due to accumulation of excessive fluid inside the pleural cavity. And we have two mechanisms of accumulation of pleural effusion inside the pleural cavity. We have the mechanism of exudation and the mechanism of transudation. We explained the mechanism of exudation in class, and I will be repeating it, but transudation needs more extensive explanation. So exudation is usually due to the presence of secretion. So we have if this is the visceral and this is the parietal layer. So here we have the endothelium of the pleura, and these pleural cells, this is the pleural endothelium, the cells lining the cavity of the pleura. And of course, this is the lung tissue, okay? So what happens is that the pleural cells or the pleural endothelial cells will secrete fluid. So the process of exudation involves secretion of fluid, secretion of abnormal fluid. It's not the normal fluid that is usually secreted by the pleural cells, secretion of abnormal fluid by the pleural endothelium. Why do the cells of the pleural endothelium secrete abnormal fluid? Maybe because of inflammation, maybe because of inflammation, or it's actually due to inflammation. And this inflammation might be viral inflammation, or it might be bacterial inflammation, or it might even be inflammation due to invasion by cancer cells. In all these conditions, there will be an active secretion into the pleural space. In such cases, the exudate, we call the fluid an exudate. We call the fluid an exudate. So this abnormal fluid in such a case will be called an exudate. And because it is an exudate, then it will have a different composition. It will differ in composition from the normal pleural fluid. So the exudate is different in composition. It's not similar to the normal pleural fluid. How does it differ in composition, the exudate? How does it differ in composition? It will have more protein molecules, and these will be the proteins of inflammation. We haven't yet studied or discussed proteins of inflammation, but maybe one day we will be discussing them. So they are the proteins of inflammation. There will be more white blood cells, and these white blood cells, of course, are there in order to fight the viruses or the bacteria, and there might be less glucose because glucose will be consumed by the white blood cells, plus or minus cancer cells if the condition is cancerous. But there is also another important characteristic of the exudate, is that there will be an increased concentration of an enzyme called LDH enzyme. This LDH enzyme is normally present inside the pleural cells, but when the pleural cells are damaged, it is released outside the pleural cells, and LDH will be released into the pleural space. Furthermore, LDH is present in the blood, and because there is increased permeability of the blood, then LDH will also be released into the pleural space. So we have two origins for the LDH. It might come from the inside of the cells, and released when the cells are injured, and it might come from the blood, and it is released because there is increased permeability of the capillaries, and the pores of the capillaries are now wider. This is all what you have to know about exudation. And now we're going to talk about the second factor, which is transudation, as a second cause of pleural effusion. So what is transudation and how transudation helps formation of pleural effusion? In order to understand the process of transudation and how it results in accumulation of excessive fluid inside the pleural space, we should talk a bit about osmotic pressure, about certain concepts like osmotic pressure. First, of course, osmosis, and then osmotic pressure, and then colloidal osmotic pressure OP, and colloidal osmotic pressure or oncotic pressure. I know they are not written on the slides, but they are very important to understand, and they will be very important to you in your college study. And it's a good opportunity for you to understand them now at a slow pace in the high school, rather than be urged to understand them in the college with plenty of information in parallel. So what's all this and how is it related to transudation? There is also a fourth term that we should know, which is hydrostatic pressure. Hydrostatic pressure. We will start by hydrostatic pressure because it's the easier one, and then we will review together osmosis and then understand osmotic pressure and colloidal osmotic pressure. If this is a blood vessel, say a blood capillary, and that blood capillary has openings or pores or fenestrations between the endothelial cells, and of course inside there is the blood, and blood, as you know, consists of liquid plasma, which constitutes about 54% of the volume of blood, and consists of cells or the cellular components like the red blood corpuscles, the white blood cells, and the platelets. And inside this liquid plasma, we have substances, solid substances, that are dissolved or suspended in the liquid plasma. So we have salts that are usually ionized, like, for example, sodium chloride or potassium chloride. And these, because they are ionized, they are completely dissolved in the water of the plasma. But we have another thing, which is the plasma proteins. The plasma proteins like what? The plasma proteins like albumin and globulin. Plasma proteins like albumin and globulin. And these plasma proteins are secreted by the liver. They are formed by the liver. They are secreted by the liver. Now, these plasma proteins are characterized by being non-ionized. So they differ from sodium chloride in the fact that they are non-ionized, and they are not dissolved because they are larger than sodium chloride. So they are suspended in blood or suspended in the plasma of the blood. Now, how is this important This is important because these molecules, like, for example, sodium chloride molecules, these molecules, like sodium chloride molecules, this is sodium chloride, and the other molecules, which are the plasma proteins, these molecules attract water to the inside of the blood capillary. They attract, so say, for example, this is albumin and this is globulin. They are much larger and they are not completely dissolved. We can see them suspended in blood. Of course, they are microscopic. We can see them with an electron microscope. Whether we are talking about albumin and globulin, or we are talking about sodium chloride, they all attract water to the inside of the blood capillary. So they pull water through the pores to the inside of the blood capillary. So they exert a pulling force on the water that surrounds the blood vessel. Because as you know, let's first draw the arrows that represent the pulling in of water by the molecules of sodium chloride. So similarly, sodium chloride will pull water inside. So both of them are pulling inward. They pull inward water. They pull water from where? From the fluid that surrounds the blood vessel, and that is called extracellular fluid. And the extracellular fluid is connected to the cytosol of the cell or the cytoplasm of the cell. So if you pull water from the extracellular fluid, then you pull water from the cell. Okay, so this is the importance of sodium chloride and the plasma proteins that are inside the blood. They pull inward. But meanwhile, there is an opposite force that is called the hydrostatic pressure that pushes outwards. So if we draw the blood capillary once again, and we draw the pores or fenestrations once again, then the plasma inside the blood vessel, as we said before, is 90% water. So this water inside the blood has a pushing force outside. So it's the opposite of what sodium chloride and plasma proteins do. So there is a pushing force outward, and it pushes fluid outward. It pushes the fluid part of the plasma outward. How do we call this pushing force outward? We call it hydrostatic pressure. Hydrostatic pressure. So what is hydrostatic pressure? It is the pressure of the fluid. Hydro means water, so it is the pressure of the liquid or the fluid on the walls of the container. Here, of course, on the walls of the blood capillary. On the walls of the blood capillary. So here, at the end of the day, we have two opposing forces. Normally we have two opposing forces. What are these two opposing forces? These two opposing forces are the hydrostatic pressure that pushes outward, the hydrostatic pressure that pushes outward, and the inward pressure that pushes inward. So here we have out, and here we have in. In the inward, this is a pushing force, so the hydrostatic pressure pushes out, it pushes out, whereas we have another inward pulling, an inward pulling force. This inward pulling force is caused by sodium chloride and other salts, as well as by the other plasma proteins, which are called albumin and globulin mainly. So if you have a hydrostatic pressure that's much higher, how is this related to pleural effusion then? If in the pleural space, if this is the visceral pleura, and this is the parietal pleura, and here you have a blood vessel or a blood capillary where the pushing force outward is much greater than the pulling force inward, then there will be accumulation of fluid inside the pleurals. So when is there accumulation of fluid in the pleural space? When the pushing force outward, when the pushing force outward is much, much bigger than the pulling force inward, This results in what? This results in accumulation of fluid inside the pleural space. Accumulation of fluid inside the pleural space. Accordingly, we can say that pleural effusion results from either increased hydrostatic pressure, or decreased pulling inward. And we will give another more elaborated name to this, pulling inward. The pulling inward force, we call it the oncotic pressure or the osmotic pressure. So the pulling inward force is called osmotic pressure or oncotic pressure. Osmotic pressure is the pulling inward force due to sodium chloride. Oncotic pressure is the pulling inward force due to the plasma proteins, albumin and globulin. Whereas the increased hydrostatic pressure occurs whenever there is increased fluid in the vessels. For example, in heart failure, we have increased fluid pressure in the blood vessels, so there is increased hydrostatic pressure. And now what decreases albumin and globulin and therefore decreases oncotic pressure is liver cell failure. So why the oncotic pressure decreases, which is the pressure due to albumin and globulin. The oncotic pressure decreases in case of liver cell failure. Why? Because the liver is not capable of making albumin and globulin. Liver cells are failing. Liver cells can no more produce albumin and globulin, can no more produce albumin and globulin, or because of a renal disease that is called nephrotic syndrome. It's a disease of the nephron where there is loss of albumin in urine. So if you lose albumin in urine, albumin will be very low in the plasma. There is loss of albumin in urine, and therefore there will be low albumin in blood or in plasma. The last extracurricular piece of information we're going to discuss is what we call osmotic pressure versus oncotic pressure. Now, this is osmotic pressure versus oncotic pressure. Now, imagine we have a blood vessel, and inside the blood vessel, we have sodium chloride molecules. Then these molecules of sodium chloride will absorb water by osmosis. And the more you have of sodium chloride, the more you will have of osmosis, or the more water enters by osmosis. An important concept that is necessary to know for theoretical purposes is osmotic pressure. What is osmotic pressure? Imagine that the water is entering by osmosis in this direction. So the osmotic pressure will be the pressure that is needed to stop osmosis or to counteract osmosis. And needless to say that the more you have of sodium chloride, the more you have of water that enters by osmosis, and the more the pressure needed to stop osmosis, which we call the osmotic pressure. So osmotic pressure, the definition of osmotic pressure is the pressure needed to stop osmosis. And it is directly proportional to osmosis. If osmosis increases, the osmotic pressure increases, and therefore the osmotic pressure is an indication of osmosis. So if this is the osmotic pressure, what is the oncotic pressure? The oncotic pressure is nothing but the osmotic pressure due to the plasma proteins. The oncotic pressure equals the osmotic pressure created by or due to the plasma proteins. The plasma proteins. And therefore, the osmotic pressure can also be called the colloidal osmotic pressure. The colloidal osmotic pressure. So to wrap up, we can draw the forces. So if this is the blood vessel or the blood capillary inside the pleural space, so we will have an outward pushing force, which is the hydrostatic force or the hydrostatic pressure that pushes water outside the blood capillary. And we have two inward pulling forces, pull one and pull two. Pull one is due to the ions like sodium chloride. The pull two, or the pulling force two, is due to the plasma proteins, which are albumin and globulin. This one is indicated by the osmotic pressure, or is equal to the osmotic pressure, and that one is the oncotic pressure. So we have three forces, the three pressures the hydrostatic pressure pushing outward, and 2 inward pulling pressures, the osmotic pressure and the oncotic pressure. If for any reason the hydrostatic pressure, usually there is an equilibrium between the hydrostatic pressure and the sum of the osmotic pressure and the oncotic pressure. If for any reason the hydrostatic pressure, which pushes fluid out, is much higher than the osmotic and the oncotic pressure together, then we will have accumulation of fluid in the pleural space. How can we see pleural? If, of course, we talked before about the clinical picture, but before talking about the clinical picture, I would like to read the first paragraph here. So the pleural effusion is abnormal accumulation of fluid in the pleural space. Exudation and transudation are the causes. So we have exudative pleural effusion, like in inflammation. Pneumonia is inflammation of the tissue of the lung. It might be bacterial or it might be viral. We might have autoimmune inflammation where we have antibodies in the pleural space. It might be due to certain drugs like chemotherapy that might cause inflammation of the pleural membranes, or it might be due to cancer itself. And exudative pleural effusion is characterized by increased capillary permeability due to inflammation, due to histamine and the chemical mediators of inflammation. In transudation, this results from increased hydrostatic pressure. It might occur in heart failure, in liver cell failure, or in the nephrotic syndrome. Now, the clinical picture of pleural effusion is chest pain, and we said that the chest pain at the beginning is sharp, localized pain when it is only pleurisy or inflammation of the pleura. It is sharp, localized pain, but later on, when pleurisy is converted into or results into pleural effusion, the pain will be dull and diffuse pain. But in all cases, it affects breathing and results in dry cough, fever, orthopnea. Orthopnea means difficulty breathing only when you lie down because of the fluid, and the fluid moves as you move. Then if the patient is upright like this, the pleural fluid is at the bottom only. But if the patient sleeps like this, then the pleural fluid will reshuffle or redistribute itself and will cover the whole lungs, will be redistributed over the whole lungs, and this is the cause of orthopnea. So orthopnea means that you have dyspnea or difficulty breathing only when you lie down. As I said before, if you use the stethoscope, which is in Arabic al-sam'a, then the stethoscope helps you auscultate the lung. Auscultate means that you hear or you listen to the breath sounds. Of course, any area that is covered by pleural effusion will have either minimal breath sounds, diminished breath sounds, or absent breath sounds. So if the pleural effusion is minimal, you will have diminished breath sounds, but if the pleural effusion is massive, then you will have absent breath sounds. As we said concerning the X-ray findings, the fluid first obliterates the costophrenic angle, and then the radio opacity increases until we have a fluid level. And that fluid level in the lung usually has a concave upper border, which we call a meniscus. So if you find a basal lung opacity, with a fluid level, with a clear defined fluid level. And if this clear defined fluid level is concave upwards and forms a meniscus, then we are talking about a pleural effusion. Of course, as I said in class, sometimes pleural effusion is associated with trauma to the chest, and there is both fluid, which is the effusion, and on top of it, there is entry of air inside the lung. So you see the effusion, which is opaque and white, and above the effusion, you see something black, which is the air, which is very translucent or radiolucent, and therefore it appears black. In such a case, you will find that the level between the fluid and air is not concave upward. There wouldn't be a meniscus, but there would only be a flat separating line between the fluid below and the air above. In order for you to visualize the fluid, even in the costophrenic angle, the minimum amount of fluid that accumulates or that has accumulated in the pleural space should be 250 milliliters. The smaller fluids, if you have a small amount of, this is the amount of fluid that is necessary to be for the pleural effusion to be visualized if the patient is in the erect position, because the fluid settles down by gravity. But if there is minimal fluid, if we have less than 250 milliliters, you would be able to visualize only when the patient is in recumbent, lying down, and in the lateral decubitus position, meaning that he is lying on one of the shoulders, on one of the sides, and flexing his legs. This is what we call the lateral decubitus position. Of course, the treatment is a causative treatment, which is the treatment of the underlying cause, and drainage. And we said before that drainage is a symptomatic treatment, because this treatment, it is a symptomatic treatment because it only causes relief of the symptoms of pain and dyspnea, but it does not treat the cause. Drainage is not only for symptomatic treatment, but drainage is also for diagnosis. After you aspire the fluid, you can analyze the fluid. And when you analyze it for several components. As we said before, you can analyze it for proteins, you can analyze it for glucose, you can analyze it for white blood cell content, for autoantibody content. You can also analyze it for the famous enzyme that we mentioned, which is the LDH enzyme. Of course, drainage of pleural effusion is important because, as we said, it is important as a symptomatic treatment and as diagnosis, but there are two precautions. First, it should occur under complete aseptic conditions in order to prevent introduction of infection into the pleural space. And second, it should be air sealed or airtight, because if it's not airtight, you would introduce air inside the pleural space and you would result in collapse of the lungs. If you introduce air inside the pleural space and you compress the lungs, and this is what we call pneumothorax. Pneumo means air, thorax. This is a condition we will be studying, inshallah, next week. So it should be completely aseptic, it should be airtight in order to avoid introduction of air, collapse of the lungs, and pneumothorax. And here you can see the pleural effusion. This is of course the shadow of the heart, the silhouette of the heart. This is the middle line, and you can see the pleural fluid that surrounds the lung. Of course, that pleural fluid is characterized by complete obliteration or filling in of the costophrenic angle, complete obliteration or filling in of the costophrenic angle. Of course, where on the right side, the right costophrenic angle, because as you see, the left costophrenic angle is clear, and you can also see this concave upper border, which is the meniscus. Here, it's both pleural fluid, it is both pleural fluid, and above the pleural fluid, we can see increased radiolucency, It is more black because there is air that has been introduced, and that is that air that flattened the upper surface, and therefore this is a condition called hydropneumothorax, means that it's a more complicated condition where we have both pleural effusion and at the same time air in the pleural space. Of course, this X-ray is a normal X-ray. I should have put it on an earlier slide. This is a normal X-ray. You can see the normal radiolucency of the lung, which is gray, dark gray. You can see all the ribs. You can see the clavicle. You can see the cardiac silhouette. You can see the diaphragm. And you can see that both costophrenic angles are free. Here we have a massive pleural effusion on the right side that covers the whole surface of the right lung. Of course, during our study of the cardiovascular system, we will be studying in detail how to read an X-ray and what are the findings that are normal and what are the findings that are abnormal on a chest X-ray. We will stop here and we will be continuing next time and studying a new disorder, which is pneumothorax.